Okay, great. Let's go ahead and get started. We have a lot of great information to fit into a short time together tonight. Thank you guys for being here. My name is Colleen Christensen. I work with the Lung Cancer Initiative. I'm the Patient and Community Outreach Specialist, and we're really excited to have this presentation today in partnership with Atrium Health Wake Forest Baptist, talking about health disparities in lung cancer. So I'm going to pass it off to Dr. Bell to get us started, but first, just a few housekeeping items. Feel free, as any questions arise during the program, to put your question in the Q&A box. I will be moderating a question and answer at the end of everyone's presentation at the end of the program. But feel free to send the questions as they arise, and we'll get to those at the end. And I do just want to put a little plug while I have your attention at the beginning that November is Lung Cancer Awareness Month, which is coming up very quickly. So I'm going to put in the chat a link to sign up for our emails. We'll be sending out information soon to our through our newsletter about Lung Cancer Awareness Month and ways you can get involved and advocate. So with that, I will pass it off to our first speaker this evening, Dr. Ronnie Bell. Dr. Bell is the professor in the Department of Social Sciences and Health Policy at the Wake Forest School of Medicine and the director of the Office of Cancer Health Equity at Wake Forest Baptist Comprehensive Cancer Center. And he is going to be giving us a beginning presentation today, explaining health equity, what that is, and then we'll get into the context of health equity in lung cancer. So Dr. Bell, thank you so much, and take it away.
Thank you, Colleen. And can I get a thumbs up that you can see my slides and hear me okay? All right, very good, thank you. So as Colleen said, I was asked to give kind of a 30,000-foot view of health equity and how that sort of plays into the work that we do at the Comprehensive Cancer Center at Atrium Health Wake Forest Baptist. So I'm happy to speak to you all tonight, and happy to be presenting with my colleagues, Dr. Jimmy Ruiz and Ms. Carla Strom. So when I do presentations like this, when I do presentations like this, and there seems to be a lot of interest in the issues around health equity these days, I like to start with this quote from Dr. Martin Luther King Jr., which is, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And I like this quote because it speaks to the depth and breadth of the issues that we have been struggling with for a while. The depth of this issue is that, you know, of all the things that Dr. King dealt with in his short time on this earth, the one that he identified in his own words as being the most shocking and inhumane is inequality or injustice in healthcare, and by extension, injustice in health or health outcomes. It also speaks, I think, to the breadth of this issue, because if you look at the date of when he said this, March 25th, 1966, it's an issue we've been dealing with for a long time. And so I hope to be able to sort of enlighten you in this area, and would certainly be happy to answer any questions as we go through this. So, you know, just in a way of terminology, so you know, we oftentimes use the term health disparities, and health disparities is sort of the simplest way to break it down is measurable differences or gaps seen in one's a group's health status compared to another group. And you could also include in that not just health status, but measures of health care or healthcare quality. And that's really been a theme, you know, going back to some of the classic works in the space of the what's traditionally known as the Heckler Report, or also known as the Black and Minority Health Report from the what was the Department of Health, Education and Welfare, now the Department of Health and Human Services. Another classic report was a report called Unequal Treatment that came out from the National Institute of Medicine, which came out in 2003, which really focused on disparities in health care. So identifying particularly racial and ethnic differences in the quality and the accessibility of healthcare. And then there's a number of agencies that provide reports now. The CDC probably does the best job of providing an annual report on health disparities, but also there's agencies like the Agency for Healthcare Research and Quality, or ARC. They do a very comprehensive report on a number of different health outcomes, and I'd certainly encourage you to take a look at those for your reference. But there's another report that came out just this past May from the Kaiser Family Foundation, where they took a compilation of health status measures and looked at those, because when we think about traditionally how we have looked at or considered health disparities, we oftentimes, our first emphasis is on racial and ethnic health disparities. So how do African Americans or American Indians or Hispanics compare to non-Hispanic whites? But this report that came out just a few months ago, they took 27 health indicators, I guess most common health indicators, and looked at the 5 major racial and ethnic populations, minority populations in the U.S., and compared those indicators to the non-Hispanic white population. And so you can see here, so basically the graphic tells you, so the orange is what we really need to focus on. Did this particular racial and ethnic minority group, how did they compare for these health status measures to the non-Hispanic white population? And you can see for African Americans, 19 of those 27 were worse. For American Indians or Alaska Natives, 17 were worse. For Hispanics, 14 of the 27 were worse. So this kind of gives you an indication of sort of the compilation, if you will, of these health disparities. And we in our catchment area, which includes 58 counties in Western North Carolina, Southwest Virginia, and Southern West Virginia, we identify a number of disparities as it relates to cancer outcomes. We see a 6% higher overall incidence of mortality for African Americans, 15% higher for African American women for breast cancer, and 15% higher for prostate cancer, and then a 9% higher, that was incidence, and then 9% higher breast and prostate mortality rates. And then for rural residents, so another way that we oftentimes look at disparities is a comparison to urban versus rural populations. So the rural communities that we serve have a higher, 13% higher overall cancer mortality rate compared to the US rate, an astounding 30% higher lung cancer mortality rate, and a 7% higher brain cancer mortality rate. And then oftentimes, it's not incumbent upon us to look at these disparities within individual boxes. So we know, for example, there's an intersectionality, if you will, of these different disparate populations. And so we look, for example, for the African Americans in our rural community. So having both a racial and a geographic disparity, we see that for African Americans, there's a 35% disparity compared to the US in the likelihood of dying from colorectal cancer. And so, as you go upstream from that, we can look to see, okay, well, what are those risk factors that contribute to these disparities in cancer incidence and cancer mortality? 2 of those certainly are looking at screening rates. So we know that in our catchment area, our patients, or the population in our catchment area is less likely to be screened for mammography. They're less likely to be screened for colon cancer. They're a significantly higher rate of cigarette smoking in our catchment area relative to our discussions tonight on lung cancer, and also higher rates of obesity in our catchment area compared to the US rates. So along those lines, there's been more and more emphasis and discussion around the principles of what's called health equity. So moving away from looking at, okay, well, we see these differences in this health measure or this measure of healthcare. Well, what explains that? Why do we see this difference? Is it just is it an anomaly, or is it something that we need to have a better understanding of? And so we sort of look more closely into the principle of what we refer to as health equity. And I love the definition of health equity because it's pretty straightforward. It just health equity is the achievement of the highest level of health for all people. And really that sort of gets at the gist of what we're trying to achieve. We're trying to say, look, we understand that there's that difference there between non-Hispanic whites and African Americans. And so we want to close that gap, but we also want both of those groups to have the highest level of health, regardless of the outcome. And so obviously for us, we're very interested in looking at saying, we want the people in our catchment area to have the highest level of care or the highest level of health as it relates to cancer prevention, as it relates to cancer control, survivorship, all of those different areas. And so you will see oftentimes different sort of graphic images that try to look at the concepts of what we refer to as equity versus equality. And so I like this particular one because what it's trying to show is the difference between equality, which refers to input, related versus equity, which refers to outputs. And so in the top line of the cartoon there, you can see where there are the four different individuals there who have a different capacity for riding a bicycle. And so as it relates to a health outcome, if we want everyone to have the highest level of health, the equivalent of everybody being able to ride a bicycle, then we need to sort of think about, okay, well, different people are coming from different measures of, or different exposures or different levels of this disparity. And so we need to sort of think differently about how we respond in each of those circumstances. So the equity here is that the mode of transportation is modified based on the individual's needs. And so similarly, when we think about equity, we need to think about, okay, there are populations that we serve that have disparities that we need to be aware of and be willing to address. And so kind of along those lines, there has been this additional focus on what we call the social determinants of health. And the social determinants of health, by definition, is the conditions in which people are born, grow, work, and age. And sometimes people add to that pray, because we know the importance of faith in health. So the conditions in which these factors sort of play themselves out and how they influence health at different levels. So we know that, people, that the environment that people live in, the level of formal education that someone has, the access to transportation. We know that food insecurity is a huge issue, and obviously access to healthcare, not only access to care, but access to quality care, violence and poverty. We kind of know all of those things are determinants of how healthy a community can be, but it hasn't been until recently that we've known the extent to which each of these factors contribute to health outcomes. And so the University of Wisconsin Population Health Institute came up with this model that said, if we were to look at the two most commonly used measures of the health of a community, which is length of life and quality of life, or life expectancy and quality of life, what contribution do different factors, health factors, play into the differences in these health outcomes between one community and another? And so they came up with this model here that said they roughly, and I know there's some overlap, but roughly 10% of these, the difference in these health outcomes can be attributed to the physical environment of in the community. 20% is related to the access to care and the quality of care that the people in the community receive. 30% is related to health behaviors like tobacco, alcohol, diet and exercise, sexual activity. But then the biggest contribution, 40%, is these social and economic factors like education, employment, income, family and social support, and community safety. So if we're going to have an impact on these disparities that we see, and particularly these persistent disparities that exist for these 50, 60, 70 years, we need to be thinking more upstream and thinking about how we can invest in addressing these social and economic factors. And I like this quote from Dr. Tom Frieden, who's the former director of the CDC, who said that your longevity and health are more determined by your zip code than they are by your genetic code. So it's a pretty astounding statement for someone from the leading public health agency in the country to say that, we can do a better job of understanding your health status, your life expectancy, your quality of life, if we looked at what zip code you lived in versus looking at your the genome in which you are constructed. And also, obviously, in light of everything that's happened over the past year and a half in this country with the social justice movement, there's also been a focus on how structural racism comes into play as it relates to how these social determinants are manifest themselves within communities. And so organizations like the New England Journal of Medicine have been more intentional about focusing efforts on how structural racism has impacted the US healthcare system, but also how it's affected a number of agencies across our country and how it can contribute to these health disparities. And obviously this is something that health systems are very interested in understanding. We know that the United States, by far, it's not even close, the United States spends more per person on healthcare than any other industrialized country in the world. And yet our life expectancy only ranks in the mid-30s as it relates to the countries around the world. And so understanding how our healthcare dollars can influence health disparities, but also understanding how we can address these upstream factors and make sure that our healthcare dollars are well spent is something that is very important. And obviously, COVID has played a major role in sort of bringing to light some of these factors, some of these social determinants. We've known from the very beginning of the pandemic that racial and ethnic minority populations have been and continue to be more affected by COVID. And so if we look at sort of the three indicators of COVID-related disparities, racial and ethnic disparities, cases, hospitalizations, and deaths, we see that American Indians, Asian Pacific Islanders, Black and African American populations, and Hispanic Latino populations are all more adversely affected than the non-Hispanic white population. Some drastically, for African American Indians, 4 times more likely to be hospitalized, more than 2.5 times more likely to die compared to the non-Hispanic white population. And so fortunately, there's more and more attention from agencies that focus on these issues, bringing them to light, making sure that we are aware of how these social determinants are impacting health and how we can move from health disparities towards health equity. This is a really nice report that was done by the North Carolina Office of Minority Health and Health Disparities. It highlights some of these key indicators. It shows, for example, where we see disparities in these social determinants across racial and ethnic minority populations. So for particularly African Americans, American Indians, Hispanics, lower levels of formal education, higher levels of unemployment, lower medium household income, higher poverty rates, higher levels of disability, all of those things that we're seeing that play themselves out downstream in lower quality of life and lower life expectancy. And I was fortunate enough to be the co-chair of the Healthy North Carolina 2030 Task Force that met last year to set 10-year goals for the state, which it has done for the last 30 years. But what we decided to do this year is, instead of just having this long list of health outcomes like cancer and diabetes and heart disease, and say, in 10 years, we want to have this level of heart disease deaths or cancer deaths, we said we want to focus on the University of Wisconsin population health model, and we want to be more intentional about saying our state needs to address some of these social determinants. And I know that the typing's pretty small here, but this was the health indicators that we came up with. So we did have indicators like life expectancy and infant mortality and suicide rates, but we also had things like unemployment and incarceration and adverse childhood experiences and housing and all of these issues that should provide us a more comprehensive picture of what we should look like as a state. And so for each of these indicators, we had this very well documented breakdown where we looked at where we are now for this indicator and where we hope to be by 2030, and particularly looking at it geographically, so looking particularly in more vulnerable counties across the state, but also looking at these differences across racial and ethnic, the major racial and ethnic populations in our state. And so we did one for life expectancy, as I said. We also did one for infant mortality, and particularly, infant mortality for African Americans and American Indians who have tremendously high rates of these disparities. And health systems are also incorporating this emphasis on social determinants and health equity in their training curriculum. And this is a paper that was published in a very prominent journal, the JAMA Open Network, this past March from some colleagues at Wake Forest at our medical school, who was reporting on the efforts to incorporate health equity training into the medical school curriculum for their trainees. And so you can see here that what they've done is look at different places within the third year clerkships to say, how can we better help our students, our trainees understand social determinants? And so they looked at, so within the anesthesiology clerkship, there's a training on implicit bias and pain. In the OBGYN clerkship, there's a training on women and infant health and health disparities. And the surgery, in the surgery clerkship, there's a focus on environmental and discharge planning. So it's a really nice way for the trainees that we have at Wake Forest to get a lot of exposure in this particular space. And so I won't spend much time. Carla will spend more time talking about what we do in the Office of Cancer Health Equity, but I will tell you that our mission, as you can see here, is that we believe that everyone should have an equal chance of surviving cancer. And so we really embrace this model of health equity that is focused on cancer across the care continuum. And obviously, this is not something that one group, one individual can do. It really requires a concerted effort across the continuum from at the individual level, at the interpersonal level, at the organizational level, at the community level, but really to make these initiatives ingrained or embedded, they need to be addressed at the policy level. So looking at policy at the local level, at the state and national level, but also even at the institutional level. So the organizations that you work in, making policies to where health equity is a priority. And I love this quote from the director, Cornell Wright, the director of the North Carolina Office of Minority Health and Health Disparities, which ties into this, which he said, health equity is not the sole responsibility of one individual or one agency, but is the collective responsibility of all of us to do better, to be better, and to help others. And so I started with the quote from Dr. Martin Luther King Jr., and I'd like to end with this quote from someone who I had the good fortune to know during her time on this earth, Dr. Maya Angelou. And she said, courage is the most important of all the virtues, because without courage, you can't practice any other virtue consistently. You can practice any virtue erratically, but nothing consistently without courage. And so it really takes a measure of courage to sort of think differently about the health of our communities and embrace these concepts of health equity to where we can do better and be better as people who serve our communities. So with that, I will end and thank you very much.
Dr. Bell, thank you so much. I have so many questions, would love to pick your brain, but I'll have to save it for the end. Thank you for sharing. And reminder to everyone else, if you have any questions or would like to ask Dr. Bell anything, please put it in the Q&A and we'll get to those at the end of the presentations. So now we're going to move on to Dr. Jimmy Ruiz's presentation. He is going to share more about what lung cancer disparities specifically look like in the Winston-Salem, Western North Carolina catchment area for Atrium Health, Wake Forest Baptist, as well as talk a little bit about disparities in clinical trial participation. Dr. Ruiz is the Associate Professor and Fellowship Site Director for Hematology and Oncology for the Veterans Affairs Medical Center, as well as a hematologist oncologist at Atrium Health, Wake Forest Baptist. He's also a member of Lung Cancer Initiative's Healthcare Provider Education Committee. So we are always grateful for his support and involvement with Lung Cancer Initiative. So thanks so much, Dr. Ruiz, and feel free to take it away.
All right, great. Thank you so much. So I'm going to talk a little bit about lung cancer in North Carolina, but we'll start with just some data. So lung cancer continues to be a major problem. It is incurable when it is in its advanced state. It has a grim 5-year survival rate of about 15%. And if you compare it with other cancer types, prostate, pancreas, breast, and colon, all those together will match the mortality that we see in cancer deaths from lung cancer. So this is data from the SEER database, a little bit dated, but hasn't changed a whole lot. So when we try to define the scope of the problem and wrap our minds around a number of lives lost to lung cancer, it's about 158,000 lives lost. If you think about Bank of America Stadium, that's about 75,000 seats. So you're essentially thinking about a combined 2 stadiums worth a year of lung cancer death. So how are we doing in North Carolina? So if you look at the state rankings by the rate of new cases, you can see that we're at, unfortunately, we're not the average, which is here, 58.7, but we're a little bit below target at 68.0 age-adjusted lung cancer rates per 100,000. So looking at our ranking, we're not doing so hot. We're about 41st out of 50. And if you take a deeper dive and think about some of the things that Dr. Bell brought up in terms of disparities, one of the glaring things we see in lung cancer is the rate of new cases by racial and ethnic groups and how they differ. So, for example, we see an incidence rate of about 64.3 out of 100,000 Black Americans, which is higher than the national average. So if you look at the actual numbers, you compare it to the nation, which is here in the light blue, and then the dark blue. The dark blue is the nation. North Carolina is the lighter blue. But if you look across in terms of those impacted that are white, it is much lower than the rate of white Americans in North Carolina. So a lot of this goes back to lung cancer early diagnosis. And looking at the same breakdown, you can see that the rate of 19.2% among Black Americans in North Carolina, not really different than the national rate in terms of diagnosis of lung cancer early, but is significantly lower than the rate of 23.5%, which is among white Americans in North Carolina. So we can speak about North Carolina in a broad sense, but we can also talk about the catchment area. And this is kind of looking at the data from the perspective of Wake Forest Baptist Comprehensive Cancer Center. And you can see that we have a very broad catchment area that crosses state lines. So a lot of this has to do with the ease of getting into the city, where you have number of highways, but you can see here that it's 58 counties, 83% Appalachia, 59% rural, 88% are elevated indoor radon levels. And overall, you have a large annual cancer case mix, of which lung cancer plays a significant burden. So a little bit about that burden. So the incidence rates per 100,000 is 23% for lung. Melanoma is about 16%, just to look at other comparisons, and then much lower for the other cancers. Now, when you look at mortality rates, you can see the difference here as well. The lung cancer mortality rate much higher than that of the other cancer types that we see. And if you compare it to the US, we have a much higher rate there as well. So I'm going to go back to this slide. Incidence rate, you see a difference between the US incidence rate, much higher than the statistically significant, and then also statistically significant higher mortality rate. So why is this the case? So looking at our smoking rates, we have a very impressive distribution of smoking rates across the counties that we serve. And those counties, if you look at an average of about 16%, all these in red basically are smoking rates above the US norm. Again, a lot of this is historical, and it really goes back to the local regional tobacco health burden that's been imposed by tobacco in this area. And, you know, tobacco companies, you know, we're the epicenter for tobacco, big tobacco. We have in our region itself, we have a number of manufacturing plants, and we have a number of headquarters all within this area. So it is not surprising that these counties have elevated smoking rates. But to kind of switch gears, radon also plays a role in this. And Carlos is going to speak a lot more about this. But if you just look at the predicted average indoor radon for these areas, you can see that the action level, which is this is the number, it's 4 picocuries per liter, which is zone 1. That's the highest zone. That means that you need to take action to take care of that indoor radon level. And you can see that 8 counties have significantly high levels of radon. And then the other counties which feed into our health system from West Virginia, includes an additional 11 counties. So overall, kind of coming back to what about the disparities that we see across our catchment area, it's not much different from those disparities that we see in North Carolina, and certainly that are been documented and published on across the country. And a lot of it relates to surgical treatment, actually having access to surgical treatment and having surgery for your lung cancer, a lack of treatment, whether it's chemotherapy or directed targeted therapies, lung cancer screening. We are already seeing significant disparities in lung cancer screening, and then ultimately prevention. So whether it's tobacco, radon, or air pollution, all of these issues still pose a significant problem. And one thing that's dear to me is clinical trials, which to me is access to novel therapies. There is a clear disparity there, which I'm going to talk to you about here in a second. But before we talk about that, I want to give you just kind of the 101 of clinical trials. The 101 of clinical trials are that clinical trials are important, and they're very important because it is a prospectively planned experiment, which its main purpose is to look at the beneficial therapies and also advance the treatment paradigm. So in general, these studies are conducted under very controlled conditions. And you have to do it this way to establish and come up with well-defined answers to well-defined questions. So why do we do clinical trials? Why do we invest so much time and effort in these? A lot of it has to do because it is the definitive method to determine treatment effectiveness. Alternative to it will provide too many potential biases, which may be harmful for the patients we take care of. Also, one cannot determine in an uncontrolled setting whether the intervention had made a difference in outcome. So there's such a thing as correlation versus causation. You can actually see something just causal. The other thing is determining the side effects and complications. And as I've been shown time and time again through my own translational experience, theory is not always the best path. We can come up with a great idea and say this is going to work because of X, but oftentimes it fails. So in essence, clinical trials, to simplify, is really the why, who, what, which patients to look at, where, when, and you know, how bad are the side effects? Is it tolerable? And at the end of the day, it's so what? What did this trial tell us that we already didn't know, or how has this advanced the field forward and helped care for the patients that we see? So in general, clinical trials are formatted in phase 1, phase 2, and phase 3. Ultimately, the goal is FDA approval for these studies. So they go through the stepwise fashion. Phase 1 studies generally are very small studies. They're testing a new drug, 20 to 80 people. And then the goal is to evaluate the safety of that drug and establish a dose, a preliminary dose. It isn't until the phase 2 portion of the study that you take more patients, 80 to 300 patients, looking at the drug effectiveness, what's the safety of the drug, and then you try to determine the optimal dose or doses. And then the phase 3 portion of it is much bigger, much more controlled, 300 to 3,000 patients sometimes. It's an intended patient population, so you define the population upfront, lung cancer, stage 4 disease, and then you randomize. And mostly in clinical trials, you're randomizing against what the current standard is. So if we have a drug that doesn't work so well, you compare it to that best drug. And then efficacy versus standard of care, kind of what I talked about. So FDA approval is ultimate goal. And this is where it comes up, where we talk about the disparities in clinical trials, because a lot of our patients from underserved backgrounds, minority patients, ethnic, racial, are not participating in trials. There's a clear representation nationally. So here's the US population. And just for simplification purposes, we're going to look at Hispanics and African Americans. So our population, 72% white, 16% Hispanic, 12% African American. And if you look at participation onto clinical trials, clearly there's a huge difference there. So of clinical trial participation, only 1% are Hispanic, and African Americans, only 5%. So the lack of diversity among clinical trial participants is clear. And because of it, there's a paucity of information on multi-ethnic patient basis. So if you really think about it, segments of the population are not included in clinical trials. And if you were to look at a question, whether in those groups, is there a major difference in toxicities, you wouldn't be able to meet statistical significance. You would not be able to make it a comment or observation regarding that. So the big question is it possible to determine if a therapy in question will work for everyone? And here's where pharmacogenetic research in the past few decades has uncovered significant difference among racial and different ethnic groups. So metabolism differences, clinical effectiveness differences, and side effect profiles. And we see this throughout all types of medication, not just lung cancer drugs, but all kinds of medications, from albuterol inhalers all the way to hypertensive medications. So the lack of clinical trial representation accounts for looks at 2% of cancer studies that really have sufficient minorities to provide useful information in those populations. So you have less than 5% of lung cancer studies that have enough minorities to provide useful information. For example, Black patients made up less than 5% of trials, which subsequently led to 31 cancer drugs approved since 2015. Asians only accounted for less than 2% of US-based trials. Native American participants weren't reported in nearly 2/3 of the trials. And the Hispanics had very limited involvement in the majority of large treatment studies that changed practice. And an observation, I was at a meeting and I was able to listen to Otis Brawling, which is always a treat. So he's a very successful GU oncologist and speaks on health disparities. And I took I'm paraphrasing a little bit here, but he was talking about scientific innovation and progress. And he mentioned in his talk, he said, population disparities always increase when there's scientific progress. And that really resonated with me, because I saw, certainly he displayed examples of this through breast cancer screening, through different colonoscopy screening. So that scientific progress happened decades ago, and how it was very slow for underserved communities, minorities to uptake and benefit from those studies that were initiated. And now we're seeing it again. And we're seeing it specifically in lung cancer to two different areas. And those two different areas are precision medicine, which is biomarker-based studies looking for specific mutations in populations and treating those mutations. And we're also seeing it in immunotherapy. So what are the barriers to clinical trials? So this is an oversimplification, but it is clear that there are 5 critical barriers. And one of the biggest one is mistrust. There's a lack of comfort, lack of information. There are also some time and resource constraints associated with clinical trial participation, and then lack of clinical trial awareness. But if we talk about mistrust, we have to talk about the Tuskegee syphilis studies. For those that need a reminder, this was the most unethical clinical research study known to man. It was the U.S. Public Health Service Tuskegee syphilis study. It studied 600 African-American men to participate in various experiments over a 40-year period. And these participants were diagnosed with syphilis and given syphilis. Most of these participants were not informed of their condition or offered treatment. Many died of their disease, infected their wives, or passed congenital syphilis to their children. And then because of this, there's a residual mistrust of clinical trials, especially in members of the African-American community. So to overcome these barriers, we have to gain trust. In order to gain trust, we have to speak the language. It is often through our education as physicians, as scientific leaders, that we pick up a lot on vocabulary. And the examples that I set forward now with my experience going back home, I grew up in Chicago, went back home and saw a friend who's fairly successful. He rents homes and works hard. And one day we were just talking about our jobs, and he told me what his jobs were like and what are the pros and cons of his job. So I started talking about mine. I told him I do clinical trials, and really, as I spoke with him after about 5 minutes, I got to the point that I realized he had no clue what I was talking about. So when I went back and I asked him, "What do you think I was talking about?" He said, "I don't know. You're talking about a trial." And this is what came up in his brain. He was thinking about some kind of court trial. He's like, I really didn't understand that, how you were meshing that with medical care, but that's what I thought about. And then I said, well, what about when we were talking about the treatments? And he said, oh yeah, when you're talking about the treatment cycles. I said, yeah. He goes, yeah, I really didn't understand that, because it sounded like it had something to do with the bike. So then we talked about we're dissecting things more. What about a cell? I was talking about cell suicide. And he said, I just didn't understand that much. This is what I thought about: incarceration, cell. And then the meaning of the study or experiment. I'll ultimately said, look, this is just a study or an experiment. And then he finally just looked at him and said, he goes, I get it. You're a guinea pig. You're making your patients are guinea pigs. I said, no, that's definitely not true. So, I think ultimately speaking the language is key, and the language has to be focused. It has to be plain language. We have to help with the communication gaps. We have to come down to where the patients are for them to understand what clinical trials are. So being mindful and focused on words and intentions. And I still have a lot of problems with this. So ultimately, I tell folks who I work with, this takes lots of practice, and hopefully we get it right. So what's the other barrier? It's the physical barrier, the distance barrier, right? So here we are at Wake Forest. Everyone says, hey, you're in your ivory tower, and everyone has to come to you. And I think the times have changed for that. I think in terms of, if we really want to impact these communities, we have to bring the trials to them. So we have to bring the trials to them, or we have to create a bridge where it's easy and accessible for them to get to us. So keeping those two things in mind are essential. And we tried to do this. Here more recently, we were granted funding through the NCI to create access to targeted cancer therapy for underserved populations. It's the catch-up grant. And the goal was really simple: accrue patients, and they would like to see 24 patients accrued in a year, 12 from underserved population, with the focus being on minority underserved populations. So we did that. We expanded the network sites. We looked at co-management of trials for outreach providers, creating that bridge so they can send those patients to us and still have their provider at home. And then we sent out weekly newsletters. We scheduled screening of outreach clinics. We did systematic identification through our own electronic medical record. And I think most importantly, we started to integrate with a pilot population health navigators. So these are the population health navigators. So they have their own experiences that's been fruitful for this. So we have an African-American patient navigator, a Hispanic patient navigator, and a rural patient navigator. And because of this, our catch-up accrual was great. We actually get over accrued 31 patients. And of the 31 patients, there were 13 underserved minority patients, so 42%. So we met the goal. And this was all done. It was a lot of work, but proved successful. So I think if we think about how do we improve access and minority enrollment to clinical trials, I think the trials have to be made accessible, affordable, and equitable. We have to design trials that integrate everyone into the study. And we have to simplify, streamline, and standardize these protocol requirements. I think one of the important things is you have to have a good team, and you have to recruit, retain, and support well-trained, diverse clinical teams. And ultimately, we have to continue to provide oversight and review clinical trials to make sure that they are reaching all aspects of the community that we serve. So this is the last slide. This is about clinical trial participation. And oftentimes we think about this. This is what I think about, because this is what they're holding me to. How many patients did you put on the study to be a successful study? But really, it's more work than that. It's all about site selection, trial operations, knowledge and attitudes about the trial. But the things that we need to really think about are just structural barriers, the racism that patients have had and other discriminatory practices that we may be employing without really understanding the ramifications of that and understanding that it's actually happening. So with that, I'll stop. And I guess the questions, we'll do them at the end. Thank you.
Wonderful. Dr. Ruiz, thank you so much. Yeah, I think that last slide really covered it perfectly in terms of especially tying in what Dr. Bell mentioned. It's complicated. There are a lot of factors. So thanks for unpacking that a little bit. Okay, we're great. We're going to move on to Carla Strom. She is going, well, first, Carla is the Assistant Director of Operations at the Office of Cancer Health Equity at Atrium Health Wake Forest Baptist Comprehensive Cancer Center. And Carla is going to be sharing with us a little bit more about what their office does to address some of these issues, seeing the significant need in those catchment areas, what are the programs and ways that we try to fill the gap. So Carla, take it away. Thanks so much.
Thank you. Are we good? Can you hear me?
Yep, we're good.
Thank you. Okay, so I think get the easiest part of today, and that is to talk about what we do in the Office of Cancer Health Equity at the Comprehensive Cancer Center at Atrium Health Wake Forest Baptist. And so, as Colleen just mentioned, this is about how do we take what we know about disparities and equity that Dr. Bell talked about. What do we know about lung cancer specifically, the differences we see in outcomes and in access and in our patients, and how do we implement programs and practices that can impact this. So Dr. Bell touched just a little bit on the Office of Cancer Health Equity. So we're here to advance community engagement, clinical care, and research focused on improving outcomes for everyone in our community. And as Dr. Bell mentioned, we believe that everyone, regardless of age, gender, race, religion, financial status, or location, deserves the best care possible, and that everyone should have an equal chance of surviving cancer and surviving it well. And I repeat that because for me, that particularly hits home, as I myself am a 2-time cancer survivor. And there's no reason why I should have a better chance than anyone else of still being here 15 years later. So how do we do this? Well, we work with a focus on underserved populations. And when we use the term underserved, we truly mean that in the broadest sense possible. As you heard Dr. Bell talk about, we look at racial and ethnic minorities. We look at, could be the LGBTQ plus community. We look at geographic disparities. We look at age. Adolescents and young adults are the most underserved age group in cancer. We look at, could be based on religious preference. The second most requested, also the second most requested language of interpretation in our cancer center is Arabic. So wherever it is that the gaps are, the disparities, the data, the communities point us to is where we focus. And we do that by facilitating community engagement, supporting research focused on eliminating cancer disparities, increasing diverse participation in clinical trials, as you heard from Dr. Ruiz, assuring the highest level of culturally sensitive clinical care, and understanding the needs and removing the barriers to cancer care. So specifically around lung cancer, Dr. Bell touched on our population health navigation program, which is a very unique program. They are non-nurse professional navigators who, to my knowledge, were the only ones in the country with a program like this who serve a population instead of a cancer site. So as he mentioned, we have a rural patient navigator, a Hispanic patient navigator, and an African-American patient navigator. And what's very unique is that they are culturally concordant and, when appropriate, speak the same language as the patients that they serve. And so, as I mentioned, they are advanced professionals from multiple backgrounds. We have a master's level social worker. We have background in domestic violence, all different types of backgrounds that really, it might not make sense at first, but does when you kind of see it all come together. And we definitely provide them with a good foundation of training. And here's a picture of Maria with the, she is our Hispanic patient navigator, with Harold Freeman, Dr. Harold Freeman, who is considered the grandfather of patient navigation. When appropriate, they get certified by the Academy of Oncology Nurse and Patient Navigators. They are members of the multidisciplinary care team. So while they may not be clinical, they are still part of that team, and they work very closely with our nurse navigators. They also do community outreach and engagement, because it's just as important for them to be seen in the community before someone needs them as it is for them to be there after someone is diagnosed. And they do a lot of patient programming, like support groups and survivorship classes and other activities such as that. But what's most important is that they provide services in a culturally sensitive and linguistically appropriate manner. And so what can we learn from this? So this is a sample of patients that were served by our patient navigation program. In this analysis, there were 279 patients. And you can see this is the documented barriers to care that our patient navigators keep track of on every single patient. And you can see that the green is rural, the red is African-American, and the orange is Hispanic. And so you can see how the barriers to care that the patients experience have some differences in between these populations. And so this helps us understand the types of interventions and the types of support and resources that we need to tailor towards our patients. one of the things we also built into the role of our patient navigators is that they provide tailored clinical trial education to every one of their patients based on where they are in their cancer journey and whether or not they'll immediately be participating in a clinical trial. And this has really made a difference in the participation we see of our underserved patients in our studies. So in the first columns, that is the number of cases of cancers in these populations that we see in our catchment area, whether or not they're patients at Wake. The middle bars are what our diverse accruals look like before we implemented the patient navigation program. And then the last columns are what they look like after we implemented the patient navigation program. And so as you can see, it's had a significant impact on many of our populations in increasing their participation by simply providing increased education, knowledge, and awareness around research from someone who is linguistically and culturally concordant to them. So I touched on that they do outreach and education. We do a lot of outreach and education. We are the community engagement arm of the Cancer Center. And while we don't do all of it ourselves, we are really the boots on the ground in our office. Which, to give you an idea, when I started at Wake, I just had my 10-year anniversary in August. I was the only position in the Cancer Center dedicated to disparities. And 10 years later, when we're fully staffed, we're an office of 11, not counting Dr. Bell and Dr. Weaver, who are our director and assistant director of research integration. So it takes a village to get out in the community and do this. And particularly around lung cancer, our outreach and education, sometimes it's general, and we might be giving out lung cancer information as part of community activities that we're doing. But we have been very intentional in creating brochures, including one on lung cancer, that is both in English and Spanish to help address some of those knowledge gaps. We have specifically done, as part of our series that we have, a CME for community primary care providers on lung cancer screening. And then we do hundreds of community events a year, particularly pre-COVID. Now the world is a little different. We'll see where we get back to. But to give you an idea, in the last 5 years, which includes all this time period since COVID, we did 102 community events that were lung cancer specific, which reached over 9,000 people. So, this is really our opportunity to connect with the communities that we serve. And for example, in that top picture, that is Maria and some other folks at our table at Fiesta in Winston-Salem, which is our big annual Hispanic cultural festival on the streets of downtown Winston-Salem with amazing food. Highly recommend it. But we really do try to focus in on our underserved communities with these activities. So Dr. Bell also touched on Radon, which I moved here 10 years ago from Texas, and I did not know really what radon was, had no idea that I had to have my house tested. And so this has been something that's really fascinated me. But as you all probably know, it's the second leading cause of lung cancer. And in this part of North Carolina of the country, and particularly in this part of North Carolina, it's something that we really need to pay attention to. And I'm surprised at how even a lot of my physician and research colleagues who also aren't from an area with radon kind of don't really know about it either, and might say, oh, I should get my house tested. So we have been very intentional in also educating specifically about radon and providing free radon tests to our underserved communities through partnerships with the state and others to help bring awareness to this and to bring the information around testing, and an area that we are starting to work in health policy is what if you don't own your home? So hopefully next year we'll have more to come on our policy efforts. And then, as you also saw Dr. Ruiz point out, historically, we have a community very tied to tobacco, and as a result, see very high rates of tobacco use in our catchment area. So we can't do our work and do it correctly without addressing tobacco cessation. And so in addition to doing community outreach and engagement around tobacco cessation, and that can be talks, that can be health fairs, that can be all different things. We also developed a 6-week curriculum, an evidence-based curriculum that is our tobacco cessation program that is facilitated by our community health educator, and was changed into a virtual format last year during COVID. But we have done 12 groups, have had 64 participants, and this is in about 18 months. We provide free NRT through 2 of our community partners at the Downtown Health Plaza and in Wilkes Medical Center through Care Connection Pharmacy. And we have been able to help 18 people quit smoking completely, which is 28% of our participants. But more importantly, 73% of them decreased daily cigarette use by 57%. So it's not just about, can we get them all the way to quit? It's that, can we move them along the continuum of the stages of change or readiness? And if they didn't during this 6-week period, can we set them up to be successful when they're ready to quit altogether? And our focus within the Office of Cancer Health Equity is on community members and providing tobacco cessation. We have a different program within the Cancer Center for patients who want support with tobacco cessation. So we also offer support to our patients as well. And then we also have a program to develop research advocates. So the program is called ARM, or Advocates for Research in Medicine. And the purpose of ARM is to connect cancer patients and researchers to ensure the patient perspective is part of research activities so that we can ultimately improve outcomes. So a little bit about this program. I have served as a research advocate or a patient research advocate. I'll just use research advocate for short, for several years now, both locally and at the national level. And as more and more attention is brought to the role of research advocates, there has been an increasing need for research advocates at Wake and generally in our area. So we developed the ARM program as the first formal research advocate program at Wake Forest that we run through the Office of Cancer Health Equity, that we're hoping will serve as a model to be replicated within our center around other disease sites and other areas of research that we do at Wake. We're hoping that this helps us contribute to competitive, high quality research because it maintains patient-centered care. And this will help us ensure equity in research in a couple of ways. As Dr. Ruiz mentioned, sometimes you come up with a theory and then you take that into research and you study it and it doesn't work at all. Sometimes the involvement of a patient advocate can really impact that because they can bring that patient perspective and say, you know, patients aren't going to participate if you want to poke them and take blood once a week for 12 weeks in a row. I'm exaggerating, but that type of idea. We also advocate for underserved populations. So myself, for instance, as a bilingual bicultural cancer survivor, is always checking to make sure, besides my professional role in the Office of Cancer Health Equity, that researchers are being intentional about being inclusive of all populations and reaching out to all populations to try to help ensure that they participate in research. And I think it really does help to enhance community trust in our research programs. So who is a research advocate? I mentioned as a cancer survivor that I have served as a research advocate. In general, patients are usually, or survivors can be research advocates. We are also going to be expanding our program to include caregivers and high-risk individuals, for instance, those with genetic mutations that put them at increased risk. You really just have to be someone who's willing to learn about clinical trials, research, and grant reviews. And obviously, the three of us who are speaking today have an affinity for this line of work, and everybody doesn't, and that's absolutely okay. Being a research advocate isn't for everyone, but you have to have that openness and that interest in learning about that area of medicine. And you have to be able to provide the voice of cancer patients, not your situation. So you have to be able to provide a broader perspective and share the challenges, concerns, and realities that patients with cancer face. And then also be willing to share their research findings with the community and make them easier for patients, survivors, the community, lay audiences to understand them. And this is a picture of the advocates that we trained in January of this year virtually. And so we provide initial and ongoing training and support to all of the advocates who become a part of our program. And this is an example of the role that they can play across the research process. So they can advise on the development of research ideas. That's kind of really the early on. Maybe, what are the things that I'm involved in a lot of symptom management studies? Which are the symptoms that are most burdensome to patients? What would they prioritize? So bringing that type of information to the table. They can review proposed research and provide feedback and try to impact what that study is going to look like before it gets to the implementation phase. But even in implementation, research advocates can help with things like recruitment, retention, making sure that the educational material about the study is easy to read or tailored to the right audience. And then, as I mentioned on the previous slide, they can help in promoting research to professional and lay audiences and disseminating the results of the research that we do with the communities that help make it happen. So where are we going next? So as you all probably know and can tell from our slide deck, the Wake Forest Baptist Health, it joined into a strategic alliance with Atrium Health at the end of last year. And so now we are Atrium Health Wake Forest Baptist. And as we begin to work together as two large medical centers, it has provided some very unique opportunities, including for us to bring lung cancer screening, specifically mobile lung cancer screening, to our catchment area. So as this AACR image shows, 96% of adults age 55 to 80, and this isn't even exactly right on with current screening guidelines, but even if you're looking at those age 55 to 80 who have smoked at least 1 pack of cigarettes per day for 30 years, or 2 packs a day for 15 years, for example, and who currently smoke or have quit within the past 15 years, are not up to date on lung cancer screening. That means only 4% of people who should be getting lung cancer screening are getting it. So clearly, there's a lot to be done in this area. And so as we focus a lot on the barriers, some of those barriers, in fact, the number one barrier we see at our cancer center is transportation. And so if you can put lung cancer screening on a mobile bus and meet people where they are, you're going to have a much easier time being able to screen individuals. They can go places where they're familiar, the local church or senior center, to get their screening. They don't have to take as much time off to travel. And so we are currently working with our colleagues in the Office of Cancer Disparities at the Levine Cancer Center to bring their mobile lung cancer screening bus first to our patients at Downtown Health Plaza, which, as many of you may know, serves a majority of underserved patients, to get us started with the lung bus. And then we are hoping to move up the 421 corridor to a part of North Carolina that has very high smoking rates and very limited options for actually getting lung screening without having to travel all the way to Winston-Salem. So again, hopefully more to come on this with you all next year. So with that, I will turn it back over to Colleen so we have time for questions. And I would just say, here is our contact information. If you have thoughts and ideas about how to collaborate or are interested in any of the programs that we do, please don't hesitate to reach out. And in fact, I get all the emails from this, so you'll get to me directly. And our social media is on here as well. So please follow us so you can hear about all of the fantastic things that us and our partners, including the Lung Cancer Initiative, have ongoing.
Awesome, Carla. Thank you so much. I think these problems feel a little bit more approachable when we hear all the great work that you guys are doing to address these issues. So I really appreciate it. Okay, before we get to questions and answers, I am going to share a brief presentation, a little bit about Lung Cancer Initiative. Can you guys see my screen okay? Okay, great. Here we go. Good, okay, awesome. So I'm going to share a little bit about Lung Cancer Initiative and what our programs entail. And while we are definitely not the experts in health equity and health disparities, we work with wonderful organizations such as Atrium Health, Wake Forest Baptist, Office of Cancer Health Equity, and other partners to try to reach every corner of North Carolina and improve life for everyone affected by lung cancer. So our mission is to advance survivorship and provide support to those affected by lung cancer through research, education, and access programs. And I'm going to dive into just very briefly what we do in each of those areas and how it relates to some of the things that we've talked about and discussed here today. So research, our organization has been in existence since 2008. And since 2008, we've actually funded over $2.6 million in research here in North Carolina. It's really important to us that we're investing in research in our 5 leading cancer centers and research institutions in North Carolina. Atrium Health and Wake Forest included 2 of those 5. For reasons that Dr. Ruiz and Carla mentioned related to clinical trials and trying to make the most novel treatments, the most cutting edge therapies available to lung cancer patients and survivors in our state. And it's really exciting to see, we've been funding research for a very long time now, funding research for researchers earlier in their career, and to see that investing in their career early has jump-started careers in very prominent areas, organizations, institutions, and they've gone on to continue pursuing lung cancer research and helping kind of increasing the research and the understanding of lung cancer treatments across the board. So we also recognize access is a really big piece of the puzzle here, as Carla mentioned, with transportation being one of the largest barriers to care in Wake Forest. We have a gas card program where we provide $50 gas gift cards to help ease the burden in terms of transportation to all the various appointments, from surgery to radiation to chemotherapy. Even if someone is participating in a clinical trial, that could lead to even more appointments and closely monitoring their situation. And so we want to make sure that that high level of care is accessible to everyone who receives a lung cancer diagnosis in North Carolina. And while that's a really a big challenge sometimes, this is just one way that we try to make a difference and try to make some of this care more accessible to folks. We also have a community grant program called the REACH Community Grants. And this is where we fund programs in partnerships with local community institutions up to $10,000 per application, per project idea. And the thought is that this funding can jumpstart a new project or expand an existing project that increases access to any type of lung cancer care on the continuum, from increasing access to screening to increasing the availability and reducing the burden of transportation and other barriers for folks that are actually accessing and receiving care. So the thought is that, you know, the organizations that are in the communities in which they serve know the context better than anyone, can understand the barriers better than anyone, and are the best equipped to create and implement solutions that are really going to be effective and meet the needs of the challenges in those communities. We also, during the pandemic, launched a new program called the Patient Emergency Fund, where we provided direct assistance to patients through $200 stipends. And we heard overwhelming feedback of how helpful this was. And we learned that a lot of the challenges that lung cancer patients were facing at that time, some of them were related to the pandemic, but some of them weren't. Some of them were emergencies just related to receiving a lung cancer diagnosis and navigating a challenging healthcare environment, and you know, all of the barriers and a lot of the issues that we've talked about today. And so we've actually made this an ongoing program that we launch annually, continuing to provide that direct financial assistance once a year to patients who apply. And we also have education programs, and tonight is just one example of these programs, but we're trying to change the conversation in a lot of ways. So today is an example of a community education program that's designed for the general public, survivors, caregivers, advocates, to help spread awareness about lung cancer. Oftentimes we will have these webinars that touch on lung cancer research updates, trying to empower people who are affected by lung cancer with information and knowledge. We also have education for primary care providers and healthcare providers in general. And Dr. Ruiz is actually on the committee of physicians that are leading those efforts and helping inform those efforts to make sure that we are communicating and educating our healthcare providers to be referring those patients who are eligible for screening, increasing that screening rate from 96% to anything better, honestly. As well as making sure that they're aware of the resources available to them, organizations like Lung Cancer Initiative, the Office of Cancer Health Equity, making sure that they're connecting patients to all of the resources and really just trying to improve care in general. And advocating for lung cancer in North Carolina and beyond through health fairs. I mention oftentimes at health fairs, I'll talk about radon. As Carla was mentioning, a lot of people don't know that radon is the second leading cause of lung cancer. A lot of people have never tested their home for radon. There aren't any guidelines or requirements by our state home inspection guidelines, that governing body. A radon test is not required when someone buys a home. There's a lot of policy level things that we can do related to that, but just helping people understand also the lung cancer screening guidelines and helping someone understand their risk factor for lung cancer, if they're eligible for screening, if they need to test their home for radon. We do that at the community level through health fairs, as well as at the bigger level through media interviews, educational campaigns, things like that. And again, just mentioning one way that you can get involved and join our efforts is with Lung Cancer Awareness Month coming up in November. There is a lot of room for improvement and opportunity in terms of advocacy in the space of lung cancer. we've seen for other types of cancers and diseases in general, that when there really is a lot of advocacy and awareness behind these diseases, research funding follows behind. And that's really the key to saving lives and improving the outlook as for people who are diagnosed with lung cancer, especially when we're considering that underserved populations that aren't necessarily the most engaged in clinical trials and these cutting edge therapies, it will take time for them to adopt the newest, most innovative version of healthcare that we have. And so research is really important to that. And that's just a piece of what we do, but advocacy is really important to that. So I encourage you to get involved with us and reach out to me if you have any questions or are interested in that. But with that, I will stop sharing my screen. We can move to question and answer if our panelists want to turn their camera back on and join me. First of all, just thank you guys so much for all of the great information that you shared. I feel like really complemented each other in terms of painting a whole picture, in terms of understanding what health equity is, what it looks like in the context of lung cancer, and also in the region that you serve. For anyone who still has a question, I encourage you to put it in the Q&A box. I will kick us off with, this one might take a little while. It's a big picture question, but it kind of speaks to one of the graphs that Dr. Bell shared towards the end of his presentation, looking at all the different levels in terms of how we can make a difference in health equity at the individual, interpersonal, community level, up to the policy level. So I would just love to hear from you guys, from your experience, knowing what you know, what are some things that you can encourage folks that are logged in today to do in order to improve life for people affected by lung cancer, to overcome a lot of these barriers that are overcomes a lofty goal, but maybe make a difference in terms of some of these barriers and structural problems that we've talked about today.
I would say, there's a lot of areas, touch points there. One, obviously, advocate for expanded medical services, Medicaid expansion, access to care through local health departments, that type of thing. But really, I think, Carla touched on a lot of this. So to the extent that partnerships can be created to, provide lung cancer education, screening services, things like that, smoking cessation programs. I think that's really the best way to have the impact is to work collaboratively, embrace the quote from Cornell Wright that it's not just one individual doing this, but it's working collectively around, an area, that, we know what increases risk for lung cancer. So working in that space to increase access to radon detection resources, smoking cessation, screening, those areas.
Yeah, I agree. I think a lot of things we do, we've been talking about disparities now for a long time, and there have been some positive changes. But there's been things that haven't changed. Actually, some things have gone backwards. It's all about how intentional you're going to be when you decide you're going to do something. I'll give you an example. I grew up in a city where it was a big wrestling push, right? Everyone was a wrestler. I actually wrestled in high school as well, and there were camps all over the place for wrestling. I mean, you had these little kids, 5 years old, they're wrestling, and it was an intentional effort. And because of that, you saw output, and you saw great programs, great collegiate wrestlers came out of that, professionals. You don't see the same emphasis, I think, when we talk about diversifying our staff, diversifying efforts to, as it relates to clinical trials and so forth. I think we really need to be intentional about what we say we're going to do and really work towards those goals through investment and program development.
And I guess I would add that, it might seem daunting because you're an N of one, what can I do as an individual? But we're all members of a community, if not multiple communities. And I think just by being on here tonight, you're educating yourself, and you can take that knowledge back to your community and educate people about, hey, we got to learn more about this radon thing. Or, you know what? Clinical research is really important to being able to figure out how to cure lung cancer. Like, we need to not be so scared of research and what that means. And again, educate ourselves. Supporting those around you who want to quit smoking. Or it could be reaching out to someone that has been diagnosed. I mean, never underestimate the power that you have to make a difference in one individual's life. So I know it seems like a lot, but kind of thinking at those different levels, I think we've kind of covered them all. And so I would say there's always a role for all of us to play.
Absolutely. And I think, Dr. Ruiz, to your point, Carla's, your presentation really was the picture of like investing in these problems and really diving deep and showing up in the ways that we need to make those cultural shifts. So I just want to thank you for all of the work that you're doing, because I'm confident it's making a difference in your corner. And that's what we have to do, just do our best in our corner, in our community. And over time, that really accumulates and means something. So, and for everyone who is here, in terms of utilizing the information that in trying to start the conversation to things we're talking about, like quitting smoking, testing your home for radon, advocating for lung cancer in general. We're recording this webinar. Share the link to this webinar with someone that that you think might benefit from some of this information, or to help them understand how health issues affect people in different ways, these social determinants of health and how important they are. So that's a really great segue to my wrap up, to share that I'll be following up with this webinar recording. So feel free to share it with your community, watch it again if there are any big takeaways that you would like to look at, as well as take our survey and let us know how helpful this was, other topics that you would be interested in hearing about in the future. But thank you all so much for the information you presented. I learned a lot. I really enjoyed it, and I'm sure that everyone online did as well.
Thank you so much for having us, Holly.
Appreciate it.
Thanks, y'all. Take care.
Bye-bye.